Good evening, my senior teachers, colleagues and students. This next 25 minutes or so, I'll be sharing my experience of treating the secondary cleft lip deformities, which we often get. So when we just check into the secondary lip deformities, they're not quite rare. So almost some of the people say that it is rule to get a secondary cleft lip deformity than an exception, because almost all of them, however much meticulously we execute the surgery, they are quite often seen because various factors operate in the background. One, probably the scarring capacity. Anyway, next we'll be seeing the factors which can give rise to these secondary cleft lip deformities. So very often we see a case like this, wherein a child comes in, we do a repair, and then the child goes on to heal very well. And you can see this particular area where you can see that the scar is also almost imperceptible. The Philtral discontinuity is quite good. The Vermilion is sufficiently bugged up, and any lay person will not be able to say this child has been operated. Although to a trained eye, you can still see that the nose is still needs some correction. But this is always not the case. Most often we'll be getting some patient who has a hypertrophic scar, who has a notching in the vermilion, who has got a stretched out scar, something like that. So when you look into the factors which are causing the problem, so they can arise due to one, scar. So scar formation, because the patient's scar forming capacity is different for each individual. Although we take a lot of effort to make sure that our dissection is good, we don't handle the tissues much, and we do use the finest possible suture material and remove it early enough. Even then, the scar formation, the entire control is not in our hands. So they can land with some problems due to the scar. So when you look into the lip dimensions, either the height or width can be a problem, because very often the cleft magnitude varies between the children. Even though all are cleft lips, each one the magnitude differs. Some children may have the less height of the lip or the deficient tissues, which we need to adjust and try to get the approximation. In spite of our best efforts, we may not be able to get the good height or width, which may show up later. Even though most of the times we see that the width of the lip from the one Cupid's normal Cupid's peak to the angle of the mouth is always more than that on the cleft side, but that is not seen very much as long as you get the other things right, like a Cupid's bow, because the brain fails to notice that. Next are the landmarks. The landmarks like Philtral, the Philtrum or Vermilion. They can all be distorted in various other ways. Like Philtral, it can become discontinuous either due to the stretching of the scar, or it can, one may be up and other may be down, mismatch. There may be thinning of the vermilion, or it may be turning inside, or sometimes the whistling deformity, which can occur due to the lack of bulk over there. And next is the muscle. So either it can be due to the inadequate repair, which is done during the initial repair, or it can be due to the breakdown of a well performed muscular repair. Scar. When we come into the scar, what are the types of problems we can encounter with the scar? One is a stretched and widened scar. As we know that the skin is always under tension, and any scar tends to widen any area in the body. In spite of doing the best possible tension-free repair, sometimes this can occur, and that can cause deformity on the lip, whatever is imperceptible scar, which will be widely noticed. Next is hypertrophic scar. This is not quite often seen, but sometimes some particular patients may have This needs to be dealt with like how we treat the hypertrophic scars elsewhere, like massage, this thing that we'll be dealing with later. Third is the scar contraction, contracted scar. The scar anywhere in the lip, either like elsewhere, it always tends to contract. It's more so in case of a Millard's repair because it's a straight scar compared to the Randall Tennyson's where it is broken down. So we need to counter that also. And crosshatch marks, usually we don't get it, and as and when we do the plastic surgeons do it, we go for the finest possible material and close to the suture line. But sometimes when it's performed in a hurry or somebody who is not trained much, then we can get a crosshatch marks. These are the most difficult things to get rid of. So lip dimensions, when we see, it can be either the problem with the height or width. So when you can have a tight upper lip, when sometimes the revisions has happened and every time the scar has been excised, it can lead on to tight upper lip. Can be wide prolabium. Wide prolabium because while doing the bilateral cleft lip, if you don't adhere to the principles as enunciated, like prolabium is a fast growing structure. If you use the entire prolabium to do the repair, then we'll get an abnormally wide philtral column. So that needs to be taken care. In children, we take only 4 millimeter, in adults around 6 millimeter when we go for repair. A short lip, the contraction of the scar pulls it up and the height of the lip may be become less, more on the cleft side also. This is more common than a long lip because most of the time we get to see the Millard's repair. And inadequate rotation, that also can lead on to the Cupid's bow still staying above. White roll, as I said, there will be break in continuity that will be in between the Vermilion may migrate, and this will be eye-catching to any of the person who is looking at the lip repair. Again, the scar can pull it up. When you look into the Vermilion, notching of the Vermilion, this is quite common because people, when they don't bring in the muscle together, suturing together, then what happens is this notching of Vermilion. Even though the Cupid's bow will be okay, the scar in the Vermilion can contract. There can be hypoplastic Vermilion because there's an inherent deficiency in the tissue, and the inturned Vermilion because there is a lack of support on the cleft side. Sometimes the Vermilion, even though the best performed lip, the Vermilion may be turning inside instead of showing out. This is a very difficult problem to correct. When you look into the muscle, as long as we approximate the muscle, not only it gives the normal physiological structure while smiling, but also it takes away the tension on the skin. When we have a discontinuity of muscles, bunching on the sides, especially when the child tries to smile. So partial breakdown can happen when the muscle is repaired with tension, like in case of a projecting premaxilla. That also can lead on to this sort of problems. Philtrum and the sulcus. When you look into the landmark, the philtrum, it can be a widened philtrum, as we talked previously when we take the whole length of the whole width of the prolabium, or it can be a very diminutive prolabium. Sometimes the height it's very much less compared to the lateral lip elements. The other problem which can happen in males particularly is absence of hair in the philtrum. So that will be in a stark contrast to the lateral lip elements. So that will show up as a deficiency. And along the scar also, the hair will not be growing, and this scar alopecia is also will make sure that the lip is noticed much more. And sulcus, when you come into the gingivolabial sulcus, sometimes lack of sulcus will be present because when it comes to the bilateral clefts, the protruding premaxilla, trying to get the lateral lip elements over them will be a problem. in those cases, there can be a lack of sulcus. So all these problems can arise. So other reasons, factors which come into play for getting all these things. Why? Because there can be an inherent deficiency of tissues. Even though the clefts, all clefts are not the same. Some may be incomplete, some may be complete, very much wide, narrow. So the widened one with a narrow inherent deficiency of tissues will cause problems. Faulty techniques, that may be technical problem also, like persons who are doing it the first time uh, are not aware of it, or they are just scared to do it. They may go for an inadequate rotation, so that will still give rise to problems. Wound healing problems may be there. There may be infection, or sometimes wound breakdown, either due to infection or sometimes due to trauma also. In those cases, very difficult to immediately suture back also, because all the tissues are inflammatory. In those cases, we can have notching and or pulling up or the increased scarring. The last factor which we always, keeps us on the tenter hooks, is the growth, which again the growth potential for each child is different. This also magnifies the deformities which are barely noticeable during childhood. I'll be dealing with on natural course at a later slides. So when you look into the uh, person who has come with secondary cleft lip deformity, so we'll have to, whatever components we mentioned earlier, we'll have to assess each component in detail, both at rest and in dynamic movements like smiling. So this will show the component which is deficient. So based on this, certain people say that it can be divided into superficial or deep. Superficial is when it involves only the skin, vermilion, or the vitral component usually. So it's only the cutaneous problem that can be slightly, we can try to adjust with the uh, local flaps like Z-plasty, diamond excision, etc. Especially if the discrepancy between the two Cupid's peak is less than, I'll say less than 2 millimeter. This can be probably this. If it goes more, then we'll have to go in and do a bigger procedure. When it's called the deep, when it involves the muscles like inadequate rotation, all those things. In those cases, it may not be amenable to correction with minor procedures like these, like wedge excision, diamond excision, or Z-plasty. It will require a full-fledged. We'll have to take out the lip fully and go for a complete cleft lip repair. So when you look into the timing of corrective surgeries, whenever the patient comes in, there is no specific recommended time. So whenever a patient or child feels that they are troubled by the appearance, or it's dents their confidence, a corrective surgery can be done to help them. But you should be remembering that it's not that we should go in a hurry to get things done, because the healing potential also needs to be taken care of it. It's better to have a soft and supple lip before planning any surgery. Before the scar matures, it's better not do a surgery. But in case if it's a severe thing, we can always go in. This one child who has been repaired, it's an incomplete cleft lip only, but we can see a bad hypertrophic scar. So at this point of time, we'll have to just make sure that we reassure the parents and tell them that maybe it may this thing, and ask them to continue with the massage and the other scar management regime, so that we'll follow up the child, and depending on what it requires, we can go ahead. So what it requires for the hypertrophy is again scar massage and silicone gel application. Because difficult to have a silicone gel sheet on the child's lip, because the child may take it off. Now the silicone gel liquid, if it's applied, it forms a thin film on top of it, and it's quite helpful in managing this. So the same scar can cause contracture and can lead on to the distortion of the lip. Always in the Millard's repair, temporary contraction is present, which corrects itself over a period of time with scar management measures like massage. So over a period of a year, slowly whatever scar contracts and the Cupid's peak goes up, it will slowly drop down, provided we have done a good job on the table. If it persists, may require a surgical correction at a later date, but we'll take a call at a later date. This one particular child I always remember because this parents were unhappy when the child came for follow, but later they were quite happy. This child, you can see it's a bilateral incomplete cleft lip, and I will draw your attention to a small area of hyper pigmented area at the nasal tip, which is barely noticeable initially. And that's the child, we corrected it, and on the day of suture removal it is like this. Yeah, just everything looks fine, but the child went on and came back. It's about 3 months later or 4 months later, we are really shocked to see that all the scars which are barely perceptible initially, they become hypertrophic. This is the way it is, both the along wherever the colabial tissue is joining the lateral column, you can see that it's there, and it's slightly extending into the vermilion also, where the midline suture is coming. So just reassured the parents and told them to continue with the silicone scar massage, aloe vera, and silicone gel sheet application or the film, and they were quite well. They took it well and were following it nicely. Even now you can see there is a small hyperpigmented edge which is barely noticeable. This is the child sometime later when you can see that all the scars slowly are tending to flatten down. Still they are a bit stretched, but compared to this, it is quite okay. The same patient later came in, then when they come down and it's almost imperceptible now. But if he wants, now we can go for some revision procedure to correct it. But meanwhile, this has taken the full attention probably, and this has gone back in the attention. So the best way to treat a hypertrophic scar, especially in these cases, is just we have only pressure, massage, and silicone gel sheet. Usually I haven't tried any Kenocort injection as we do in the other areas. When you look at the Cupid's bow, there is a peaking of the cleft side of the bow. It's mostly seen in Millard's technique because it's a straight line scar, so it tends to contract a lot. It's due to the scar contracture. But if the initial position of the peak was good on table when we repair it, it will come down on its own, as we mentioned, around probably here. If it doesn't, probably it needs some correction. The causes may be due to inadequate rotation during the initial surgery or not using a back cut which needs to be corrected. Usually we do a Z-plasty just above the white roll to break the scar and prevent this from occurring. But sometimes, in spite of that, we can get it. This one girl who has been operated elsewhere, she has a number of problems apart from this. You can see that Cupid's peak on the right is low and the left has been pulled up. So we repaired it. We took down the whole thing and repaired it. So that's the appearance here. So we have managed to bring down the Cupid's bow, but still the Vermilion is hypoplastic. Apart from her upper jaw, still she will require some advancement procedure to correct it, and later we will have to build up the bulk of the lip by probably fat injection. Whistling deformity is caused by the tissue deficiency or faulty technique. It shows the teeth at rest. It almost looks like the patient has been whistling. So what it needs to build up of the height of the lip and release of the scar all around. It's more in case of a cleft lip. Here is a girl who had this thing. If you see here, you can see a barely perceptible scar. During childhood, she has been operated, most probably for a bilateral incomplete cleft lip. So the patient presented like this. So always it has a deficiency in the midline. If you see, the most of the bulk is lying on the lateral side. It has not been brought inside. So what I did was a revision. We just took down the whole thing. We took up the prolabial flap and pulled out the white roll from both sides, brought it to the midline and sutured it. And this is the picture finally. And there you can see when she purses the lips, you can see that there is a distinct groove which indicates that the muscles have not been approximated, and that's the post-operative picture. So vermilional notching, even when the Cupid's bow is lying at a transverse direction, a groove is seen in the vermilion. This used to inadequate apportion of muscles or not discarding the extra vermilion. So I remember Dr. Edenwala telling us it's a four-pronged strategy to tackle this. So what he used to do was double breasting of the muscles and suture them with a non-absorbable suture he used to insist on. And we should always have a lesser vermilion than the muscle. So if you have more vermilion than a muscle, it always going to cause a grooving. And we'll do a Z-plasty to prevent the contraction in the form of a U in the vermilion. So all these things will tackle the vermilional notching. So it happens due to scar contracture and inadequate approximation, indicated by the groove in the middle with bunching of the muscles on either side. It needs to be built up by double breasting of muscles and incorporating a Z-plasty. This particular boy, if you see, you can see that the Cupid's bow seems to be reasonably in normal position, but still the muscles have not been brought in. So what we did the same, we just took out that groove in the ellipse, this thing, and elliptical form, took it and took both this point and this point together and sutured it and double breasted the muscles underneath along with a Z-plasty. Now that we got a good appearance, aesthetic appearance. You can see the groove, minimal groove it was there, that has disappeared here. There is another girl. Again, you can see the Cupid's peak seems to be almost okay, but still you can see that area, the vermilion and the muscles are deficient. The bulk is not there. Again, the same thing. What we did was opened it up, extra vermilion which is in between, we just trimmed it off, brought the muscles together, and that's the picture what we get it. So that's a lip fullness and all others have been taken care. So in this case, there is no need to bring down the lip together. We can do it at the vermilion level itself. So this is a case of inadequate rotation. Even though it's maybe looking like that, you can see the Cupid's peak on this side, normal side is here, and the peak is on the higher side. That's due to the initial surgery where the rotation has not happened adequately. So we went on to pull it down and we brought the Cupid's peak to the normal side, and along with that we trimmed off the excess vermilion and did a muscle double breasting, bringing the bulk of the vermilion to the comparable to the other side. White roll discontinuity is another problem. Aaron, that you can see that this child had been operated earlier somewhere else. There you can see the white roll ending here, and a bit of vermilion is creeping up along with a bit of groove there due to the muscle discontinuity. So we operated on him and brought in the muscles together, and along with that the vermilion, the white roll was pulled in to give a continuous appearance. This is another patient, adult, who had been operated earlier. That's the way he presented with. Even though the other things are all okay, vermilion bulk and other things, we can see this stretched out scar which is traversing here. You can see the white roll which is discontinuous due to the stretched out scar. So again, we took it out, excised the scar, brought in the muscle, and brought the white rolls together, and that's the appearance here. The patient was happy with that. So muscle discontinuity, this is a big problem what we face, because this type of cases which have been operated elsewhere, probably by non-plastic surgeons on the day, where it's something, it may be an incomplete or a complete, where something they tried to just suture together the central lip segment and the lateral lip segment. You can see it's very bad where the muscles are, when he tries to do something, the muscles are bunched up here, and so much of scar tissue in between the central segment and the lateral, in the so much so that the nostril sill on the right side is full of scarring. So this patient was, that's the appearance preoperatively, and we again, that's the Cronin's and the Mulliken, where the principles where they say the white roll has to be derived from the lateral lip elements, that has to be brought in the center to bring us, because there is no distinct white roll in the premaxilla and the prolabium component. And the prolabial mucosa is always used to line the premaxilla so that a good sulcus can be built up. So we brought in the muscle and the vitreole from this, lifted up this thing, excised all the scar, and tended to get a near normal appearance. But still, this scar in the nostril still is remaining. That will be taken care at a later date. As of now, he is going for a massage. This is another similar case wherein something like an addition has been done. Just both the things have been sutured. You can see most of the bulk of the muscle is standing here, and the vitreole is ending here. So we had to just bring in the vitreole along with it, lifted the prolabial flap, brought it and brought the muscles in midline, and that's post-operative appearance. Tight upper lip is due to inherent tissue deficiency or loss of central part, or sometimes repeated revisions also can lead on to tight upper lip. Mostly seen in the bilateral cleft lip. Abbey flap may be provided if the lip is too short in the transverse dimensions, or sometimes in the vertical dimension also, in case there is a diminutive prolabium. This lady presented to us with this. She had a bilateral cleft lip. Somewhere else it was operated. When we see the patient, you can see that there's no resemblance of any of the anatomical landmarks. The vitreole somewhere stops here. Here I can't see vitreole. The vermilion seems to be migrated, and there is no evidence of any philtrum in the upper lip. So we decided to switch in and get all the anatomical landmarks. So we decided for a Abbey flap for this. So that's the Abbey flap we have done. Now we can see that whatever was a scarred area, we have just pulled out. The columella has also been pushed up, what was pulled due to the scar, and that area has been replaced with a normal skin, and this side is quite nice. The scarring is extensive, so this time we just put in that, and bit of scar is left behind. Later it will be excised back. The patient is happy with the result. That shows the Abbey flap just before division, wherein it has been pushed in. That's the final appearance. And still, she needs a revision. She is waiting to get a revision done. But one thing which I want you to notice is that even though we've taken so much of lip tissue from the lower lip, the scar is barely perceptible, and the lower lip looks normal. And the other advantage of the Abbey flap is that this preoperatively, the patient has a tight upper lip. There is no projection or the normal pout which the upper lip has. Post-operatively, you can see that even the columella that this been gone up, and this upper lip is giving a nice projection out. So that's the advantage. When the severe deficiency is there, you can always borrow from the lower lip to get the good appearance. Another such patient. Here also we had planned this thing, but unfortunately this patient has severe kyphoscoliosis and other systemic problems. So we couldn't get him to a general anesthesia. So finally we repaired the lip under local regional block, and again the broad nasal tip, did rhinoplasty under local anesthesia. So vermilion deficiencies or excess are also another thing which give rise to the deformity. When the vermilion deficiency is less, it can be built up by a VY advancement from side or from the labial mucosa. When it needs more, it may need extra tissue buildup in the form of vermilion labia. So, and fat grafting is an useful procedure to build up the bulk of the vermilion. Later, like the previous girl which I had shown, where we repaired brought down the Cupid's bow, but the vernier tip is later we'll be planning for a fat grafting. If in excess, which is very rare, the excess of vermilion can be taken out as a wedge or elliptical excision to restore the symmetry. Absence of sulcus is another problem which happens in bilateral cleft along with projecting premaxilla. The lateral components, even when fully mobilized, cannot get over the projecting premaxilla. So this needs to be corrected at a later date by mobilizing the lateral labial mucosa or sometimes skin grafting, which is not a greatly preferred option. This I'm showing a child who had a projecting premaxilla. We somehow managed to get the lip around, but still you can see that not much. We couldn't try to get it together. The patient grew up and later came like this. This is the area where you can see that when he shows the lip, it's still the sulcus is not there. The premaxilla is showing when he tries to show it. So we took him up for lip revision and the sulcus creation. That's the way we decided to do it, something like a V to Y. So this big V was taken and lifted up, and the lip was also lifted along with the transverse incision. So once this part of the lip was pushed on the premaxilla, the lateral side mucosa was pulled in to form a good sulcus here, as shown. So that's the patient post-operatively. There you can see that it is completely covering the premaxilla and patient is happy. It's still the immediate post-op. Later, I think it should improve. Other option is the, as I said, the Philtral alopecia. This is another patient whom we have the same different deformity. They come in like this. We build up, we pull it and close it. Again, you can see there is a alopecia where the lateral components get a good abundant hair growth. The central portion is scarred and lacks the hair. This you can try to do a abbey flap, but only problem in the abbey flap is that the hair will be growing on the other side, reverse. So that may not be a great solution. So hair transplant can be done. This can be successful in male patients who have irregularities in philtrum or scar. The success varies according to the level of scarring because more scarred, the survival of the hair follicles may be difficult, but it really provides a aesthetically good appearance. This one such patient whom we did, you can see that there is a sparse hair. So we pushed in some hair follicles, but that seems to have worked and the mustache seems to be in continuity now and the patient is comfortable. So that camouflages, one advantage is that it camouflages other scars and other things also when the hair follicles pick up well. So finally, we come to the deformities due to growth. I'll just take you through a case of where we got this bilateral cleft lip, the projecting premaxilla. This child came to us like this with severe projecting premaxilla, and this is the anterior view, this is the lateral view. So with our thing, somehow we managed to get it corrected in one stage. And that's the appearance when the child grew up. So this child was going to the school age, and they said that's okay, we are having problems. So what we did was there was a premaxillary setback. So once you do a premaxillary setback, you think, okay, that is a quite nice result. The child is quite smiling, and even here it doesn't look to be the thing. But growth is a big factor which will show your results and may spoil your entire result. So the child keeps growing, and now it's almost around 15, 16. That's the way the child presents. Lip is still seems to be okay anteriorly, but on the other hand, when it comes, you can see due to both the growth deficiency and due to the premaxillary setback, what has happened is the tight upper lip. She will require some sort of advancement and later, if needed, some sort of augmentation of the lip and later a rhinoplasty. So to conclude, so anytime we see a cleft patient, the first chance is the best to correct a cleft lip. So you always should adhere to the correct principles and bring it to do it meticulously and try to get as normal appearance as possible. But in spite of all this meticulous execution of surgery, secondary deformities can still happen due to various factors what we discussed previously. So a surgeon should be ready to do interventions at appropriate time to correct the deformities and refine the appearance of the lip. So it's always a challenge between us and the growth, the scar formation, etc. But we can always, with multiple refinement surgeries, we can always get a good appearance for the patient. The patient needs the best possible uh, result what we can give with our ability. Thank you.
Thank you, sir. It's a wonderful lecture. You covered very beautiful way, stepwise, all the deformities, secondary deformities we come across in cleft lip cases. You showed the one procedure like for protruding premaxilla.
Yeah.
So, what is the ideal time to decide the setbacks, sir? And do you do the surgical or manipulation?
Okay. Sometimes I do it bit early also. So I had a discussion about this with Dr. Edenwall a long time back. He says that whenever the child is not able to get a lip seal, it's always better to do it a bit early also, so that it gives a lip seal that will make sure that the child is able to get a good speech also. Because if the premaxilla is protruding down so much, the child will not be able to get the pa and ba, all the labial sounds. So in those cases, better that we do it quite early. He says anyway there is going to be a retrusion of growth is there, maxilla is going to be retruded. We will be correcting it with orthognathic surgery at a later date. So in that case, we can just always go ahead and try to do it.
So,
This
do you
child, I think I
recommend
did it around 3 or 4 years.
it's a just manipulation or surgical
I did an
setback?
osteotomy and pushed it behind and up and put in a K wire. That K wire was removed after about 4 to 6 weeks. It became axial K wire we passed it.
Dr. Sandeep? Sarika, any doubts in the chat box? Bhattacharya, sir, your comment.
I think Dr. Ravindra has full justice with
Yes.
extensive experience and distinct clarity of his presentation as usual. And what I want to mention is that many of these secondary deformities, even in best hands, they are unpredictable.
Yes, true.
Because of the wound healing nature of individual patients. Regarding the setback of the premaxilla, what we call as pre-Vermilion excision, there was a little problem I want to know from you also, that some people say that even after doing Vermilion excision and passing the K-wire and fix it, the premaxilla, push it back.
Yes, sir.
When you remove the K-wire, then the premaxilla remains little unstable. It's a frail premaxilla. What is your experience in that?
In this particular case, I had done only 2 or 3, sir. We didn't have face any problem. But I have seen another child which has had not exactly a premaxillary setback done from outside. That child had a wobbling premaxilla, and we tried to correct it with alveolar bone grafting once on one side and the other side. But in spite of that, that seems to be a bit of a wobbling. Unfortunately, we didn't get any problem in this particular child. 2, 3, what we had done.
So when you do the bilateral cleft lip,
yes,
there are 2 groups of people. One who says that the prolabial mucosa you need not give much importance. Bring the lateral mucosa and muscle repair.
Yes, sir. Yes, sir.
And a prolabium looks like a isolated, segment.
Yes, sir.
Whereas I personally feel that prolabial mucosa always there is tissue deficiency, and prolabial mucosa should be used because that gives you an opportunity to create an adequate or near adequate sulcus.
Okay,
so that's why I give the I unfold it completely.
Okay,
and give the incision just above the sulcus, so that whole mucosa is lifted and unfolded, and then you can adjust when you are suturing the mucosa of the lateral side. Then you can adjust how much you require.
Okay, right.
So you have that opportunity, instead of committing it in the beginning.
Okay, right, sir.
The second thing is that muscle repair under the prolabium. because prolebium we do not have adequate muscle.
Yeah. Yes, sir.
So in partial bilateral also less protruded premaxilla, it may be possible.
Yes,
But
sir.
otherwise, how do you manage the the prolebium?
Yeah, I just bring in just 2 sutures. They just hold it on, or sometimes they just hold on to the sides and just leave it. So after probably the premaxilla with the force, it goes back a bit. Probably the muscles migrate, or I'm not very sure what happens, but still they have a good smile.
The another thing is that whenever we see this lip deformities,
Yes, sir.
they sometimes people feel that it is very superficial and we can do a superficial job, just an elliptical excision and put it. But most of the time, perhaps the underlying muscle needs to be dealt.
Right. Always.
So you have to really undo it.
Yes, sir.
And this the patient do not understand, the severity of problem. They say it is only, this scar.
Yes, sir. Yes.
So even if there is a notching in the Vermilion or you have to do the muscle repair. I think that is underlying cause is that.
Okay, right.
So muscle repair is extremely important, and many times when we were doing MCH and this smile train was not there, it came much later. So we had abundance of material, and the government hospital doesn't allow you to give so many GA lists.
Okay.
So I used to do a lot of cases above, say, 14 or around 12, 13, 14 under local anesthesia.
Local anesthesia.
And we used to do full justice.
Yes.
When I look back, because we knew the repair of muscle and everything, and they used to usually cooperate very well.
Yes.
So, but of course, in private sector, you have the liberty. Even today, in government sector, there is a scarcity of OTs.
Yes.
But yeah, because of smile trend, the number has reduced in the private sector. And yeah, when you are doing, suppose, a fresh case of lip repair, say unilateral repair,
okay,
at what stage, this is for the PGs, maybe they should ask, at what stage you put the Vermilion key stitch?
Okay, sir. So I always commit initially, sort of, once before I've been trained by Dr. Adanwala at that time. So what he does is, once we do all the dissection, before closing, we don't leave the Vermilion till the last for that. So we just do it perpendicularly at that particular point. Wherever key points we have done it, we just cut it perpendicularly and take off the extra mucosa. But we retain the muscles underneath. So once the muscles, that is white roll, all the things have been approximated. Muscle also is approximated. Then we just do a small Z-plasty in the Vermilion just to correct that growing. So I don't leave it to the last this things.
Yeah, because whenever I repair, when I have finished with the muscle repair,
yes, sir,
and I'm putting few mucosal stitch from sulcus.
Yes, sir.
So at the earliest, I will put a Vermilion stitch.
Yes, sir.
Because that guides you to adjust the tissue above and below.
Below. Yes,
so that makes the job easier.
True, sir.
So that is why I asked.
Okay.
Very nice presentation. I learned a lot.
Thank you, sir. So that's another regarding the projecting premaxilla. You said difficulty about the muscle repair. Of late, one of our trainees from Taiwan, she had been doing a fellowship. Last time she came in and she was talking about that rapid premaxillary setback with a constant pressure, digital pressure for about 20 minutes after the anesthesia. We just keep pressing on it. There seems to be some yield, and it reduces the stress on the tightness on the lip. Actually, one particular child, slightly older child, I think I got a green stick fracture of the vomer also. But anyway, it went back and I was able to cover it easily, unlike the severely projecting premaxilla what was showed. So
sometimes these small tricks play a very good role,
Yes, sir. Yes, sir.
And everybody do not have these tricks. By experience, suddenly they might have thought that, okay, let me keep it pressed for some time.
Yeah, that's true. So far, I used it on 3 patients. But we do have a orthodontist who can do a nasoalveolar molding. If the child comes early to us, they get a nasoalveolar molding done. Only those who come late at these patients, we do the rapid premaxillary setback.
Right. Dr. Lakshmi?
You're muted, I think.
You have to unmute.
Yeah. Next we'll have a case discussion.